everyone. We are excited to be included in the opening night of the virtual APSA meeting, and we have a session devoted to talking about COVID-19. Obviously, this has shaken us all to the core and had profound effects on the delivery of children's surgical care. And I think as pediatric providers, we've been experiencing the pandemic in a very different way. Many of us are not as much on the front lines of it because it hasn't affected children in the way it's affected adults, but it still has very much impacted the way that we experience our day-to-day lives and we deliver surgical care to children. We're here to talk about what APSA has been doing in terms of information gathering and knowledge sharing to help everyone understand what's happening across the country in the COVID response in institutions that deliver surgical care for children. At the very beginning of this, we were all reeling and really not knowing what was happening around us locally and then especially nationally. And I found myself having lots of conversations, exchanges on email listservs, and we came together as a Quality and Safety Committee and as well with Chris Newton from UCSF in Oakland. I also just want to draw everyone's attention to the resources that we've also gathered that are being compiled on the APSA site as well as in the Quality and Safety Toolkit, ranging from checklists, OR policies around intubation, trauma protocols, all of the stuff that has been generated in the wake of the pandemic and helping us in our response. So we can learn a lot from each other. So we wanted to figure out a way that we could gather data in real time and have it be updated continuously. And that led to the development of this Google Sheet, which 51 centers have participated in with repeated updates through the course of the pandemic starting on March 31st. And we've collected all sorts of information, which I am going to give Martha-Conley Ingram the floor to share. She is a research resident at Lurie Children's.
And thank you again to the Quality and Safety Committee for this opportunity to help look through the online data access sheet. I have no disclosures and wanted to just reiterate that many of the policies in this document have been collected from March 31st onward. We've seen hospitals change their responses frequently, and this will be just kind of a summative evaluation to tell about where we are right now as we're kind of moving toward how do we reopen. So 51 hospitals responded, 19 of them are freestanding children's hospitals, and 32 of them were actually associated with an adult healthcare system. You can see on the graph on the left that over 50% of hospitals have reported yes ever caring for a COVID positive patient. We know that many of them have cared for over hundreds of COVID positive pediatric patients and also some adults. The graph on the right shows our present in-house cases that have been reported. And so now pediatric hospitals are reportedly having fewer than 5 more commonly across institutions, but there are still some hotspots that have greater than 10. We saw an immediate decrease in surgical staffing and changing in shifts. So 92% of institutions had altered their staffing schedules. 55% of institutions had actually restricted clinical or operative duties from vulnerable surgeons, those that are pregnant, older than 65, or had significant comorbidities. Trainees have also been impacted in this time. 47% of hospitals reported that their general surgery residents were told to go away from the pediatric facilities to help cover adult COVID units. 41% of institutions also have been limiting resident exposure to COVID positive patients in the operating room and also for clinical exams for PUI. And 16% of institutions actually limited all resident involvement unless it was essential. And globally, we've seen an increase in use of teleconferencing for resident education and fellow education. But now we see that 30 programs have said they've started to resume their usual resident and staffing coverage, which is encouraging. We also saw that 84% of hospitals had reported planning for adult transfers. 35% of them actually did redesignate pediatric beds to accept adult patients, and 40% of them just had plans to, but did not actually need to. We saw that 35% of hospitals were donating resources to neighboring adult facilities, in particular vents, but also in some occasions adult staffing and PPE as well. Finally, some of the major changes have been around how do we protect healthcare workers and provide their safety. So we've seen a dramatic increase. Nearly 100% of institutions reporting on this spreadsheet have implemented universal masking for patients, families, and staff. We also have seen a push for sterilization techniques as opposed to reusing N95. So most commonly using UV lights or hydrogen peroxide sterilization, decreasing visitors to 1 per patient, and treating all traumas as PUIs in order to protect our healthcare workers. We've also seen a still persistent increase in use of telemedicine for particularly outpatient consults and visitations, but also for some inpatient consults as well. Our testing times have decreased, so more hospitals are reporting that they have rapid COVID-19 tests available within 1 to 2 hours, as opposed to previously in the beginning of this pandemic, it was within days, and only 3 programs had reported any rapid testing. This decreased time has also, we think, facilitated more preoperative testing to become available. So 57% of hospitals reported that all cases except urgent were receiving a preoperative COVID test. A third of hospitals still have a limited algorithm that they can use, and 2 programs are actually starting to mandate that caregivers also get tested. Typical policies say that patients have to be tested within 48 hours of their scheduled operation. 36% of programs give up to 72 hours, and 17% of programs report up to 4 to 5 days. But one of the most significant changes that has happened in the operating room is how we approach intubation. So these 3 policies are the most common practices that are reported across hospitals. Decreasing personnel, having a wait time before entry, and that happens for nearly 80% of all hospitals in all cases. We see that 14% of hospitals report they actually ask all personnel to wear N95 for every case, and these are also the ones that consider COVID negative patients in the same way as COVID positive. Finally, only 12% of institutions actually have the capacity to have negative pressure operating rooms or designate a COVID positive operating room for intubation of those patients. And several institutions reported that they included having all personnel wear N95 with the prior 3 stated practices for any on-call, emergent, or unknown COVID-19 status patients. 2 additional practices that were interesting to me were that 2 programs have intubation itself as an AGP or aerosol generating procedure with full precautions, but then let the rest of the team come in without needing N95s after a predetermined time. And 1 program is actually having its anesthesia team feel so comfortable with COVID negative patients, but about half of the staff are moving toward using regular surgical masks instead of N95. We've seen hospitals start to offer time-sensitive procedures. So these are either that they have a varying definition of degree of time where outcomes would be expected to be worse. 34% of programs are hopeful to start scheduling elective procedures by May 11th. And an additional 56% hope to open by the end of May or early summer. The graph on the left here shows the 20 institutions who were able to provide expected dates to schedule elective procedures, and you can see the majority of them are scheduling now in early May. Of course, the means of case selection is varying more than in previous updates that we've talked about, with more hospitals using a vetting committee or prioritizing by a combination of ACS and case-by-case selections to try and stratify and schedule their means of getting these cases done. Here are the more common techniques being used to increase operative volume. So most hospitals are either optimizing the existing block time or increasing weekday operative hours to fit in more cases. A third of hospitals are seriously considering or are opening operative time on the weekends, and only 10% of programs reported using their ambulatory centers as COVID-free negative elective surgical centers. Significant barriers that we've seen reported are the need to still preserve social distancing for adult healthcare workers, having OR staff hour restrictions, needing post-operative resources, potentially ICU beds or vents that were previously given away, having more OR space that has been previously designated for adult patients, and even 1 hospital reported that their families were concerned about scheduling. So in summary, our initial response was characterized by a dramatic decrease of healthcare workers, staff in the hospitals, decrease in the elective procedures, and increasing telemedicine to a great extent. Our recovery response has been characterized by balancing the need for continued social distancing and healthcare safety prevention with increasing operative capacity and the challenges that come along with that. So I wanted to thank all of the hospitals who have provided data and encourage everyone to continue using them. And so we'll open for any questions.
It was a really fantastic job summarizing a lot of data in a short amount of time. And I'd love to hear reactions from Chris or Steve. We have Steve Stylianos with us from Columbia, New York. And I think all of us have felt deeply in our hearts for our friends and colleagues who are in New York City at this time. So we're looking forward to hearing your reactions and kind of what stage of the recovery you're at right now.
Sure. Well, first I'd like to congratulate Martha on a wonderful presentation and really covered a lot of material in a short amount of time. That was very, very well done. And it really illustrated how quickly all of us had to adjust to a situation that we never planned for, and really very few could ever have imagined. The children's hospitals all celebrated the fact that children were not as severely affected by this disease, although now we have in New York, and spreading is a new entity, an inflammatory syndrome that is profoundly serious. But nonetheless, our children's hospitals became helpers of the rest of the health system that we belong to. And Martha showed how we mobilized personnel, we mobilized equipment, we repurposed physical spaces, and we did all of that in record time, things that would have taken 8 committees and 6 months to do in other circumstances, we did in 12 to 18 to 24 hours. And the esprit de corps was literally unbelievable. Yeah, we all took care of patients in our PICU that were, in our hospital, we had a couple of 40 and 50-year-olds on ECMO that we helped care for. We did C-sections in the children's OR. We, not me, but appropriately trained individuals. We created negative pressure rooms for aerosol generating procedures. We had a COVID positive process for major surgery, and on and on. Issues around PPE, we took very seriously. As we were running out, we never felt that any healthcare worker should compromise, and that's created one of the most unsettling parts of this whole nightmare was, where are we going to run out? And when I say run out, I mean run out of PPE, run out of humans, run out of the ventilators, and we didn't. We got through it, so we all feel so much better about that. I will finish by saying it's not quite yet time to relax, because this invisible monster that we've been fighting is just waiting for us to slip up, waiting for us to be a little too casual, and we're going to have to start all over again. And I think that that's very, very frightening. I'm not sure we have the energy to do this again in such a short amount of time. So I would caution everybody to go slow, figure out your processes, make your place as safe as possible, and not overshoot and then pay a price for it. But thank you for the time to make the comments. I appreciate it.
Thank you so much, Steve. Chris.
Yeah, I want to echo a little bit of what Steve was saying. And I think my perspective on it, I want to illustrate a little bit to everybody about how we got here and where we go from here, because for us, it's been very, very meaningful. When we began this discussion, putting this together, there was several folks across the country that really, we so wanted to have a standard and a guideline and something scientific and legitimate that we could push out and tell everybody, do it this way and you'll be okay. But that was not honest, because every hospital was facing something slightly different. Every place had a different challenge and different resources, and we're at a different place in the time frame. And so we did what we could, and we began to simply share stories and bring people together like Steve to talk about, this is where we are. And Martha helped to put it on paper and to put it on some kind of logical form of this is what we're doing. The observation that I had was this was so profound on so many levels. This is not traditional science, but it was so meaningful to connect with each other across the country, to validate the things that we were doing that all of us thought was, this is crazy, how could we do this? And yet we see that we're not alone. Others are doing exactly the same thing. And it also helped to pave a path forward for us of trying our best to predict what's next by hearing what's going on with everybody else. And I think this also gets to where we are now. Like many, we are talking about planning as of today. We are now opening up to doing tier 1 cases in the OR. But to get to that point, there's several hurdles that we had to overcome. And we had to be very purposeful about all of these, figuring out what we were going to do with PPE. What does anesthesia do in the OR? How are we going to space out our waiting rooms? How are we going to do nighttime and space out the OR cases? On and on. There's 100 different questions, and everybody has struggled with the same things. Having this sharing and having this data has been very powerful to deal with the final factor in all our staff, and that's the wellness anxiety piece, which is really significant. We all appreciate we need to open up. Everybody is appropriately really scared because we all feel we're going to do this and it's going to flare and it's going to be a challenge. And having some kind of connection and perspective of what everybody is doing has helped my anesthesiologist. It's helped my nursing OR team. It's helped all the surgeons to see that they're not alone and they're working this out the same way everybody else is. And we're very grateful for that. This has helped quite a bit. And hopefully this continues so that at the end of it, we can get more scientific. But, for now, I think what you've put together is just tremendous.
Thank you guys both for those comments. And I think, Chris, I'm glad you brought up the issue of wellness and anxiety. And I think for many of us surgeons, it's been very anxiety provoking to be forced to not come to work. So you're kind of like dealing with both sides of the coin, right? There are the people who are afraid to come in and potentially get exposed and get sick. And then it's also been really hard to make yourself stay home, but we're all trying to do the responsible thing to preserve our health and our workforce and kind of be ready to step in if colleagues get sick. So Steve, you guys, there's no one that's experienced that more in a more extreme way than you in New York. I don't know if you want to make any comments. I'm just kind of like how to stay sane and how to role model the right behavior and what is the right behavior as we go through these different stages.
Well, the admiration that I have for our frontline workers is, it can't be quantified. Just day after day for 6, 7, 8 weeks now, they've really run towards the fire. And this was a fire that jeopardized their lives and the lives of their families, or potentially. And yet they were there for these patients. And the thing that was so profoundly sad was that so many patients died. They died alone. And the person who was holding their hand when they died was their nurse, because the families were not there. And I think that is going to have a very profound effect on people when they get a chance to process what they've just been through. And I think those moments, those last moments in people's lives that they were there, it's either going to bring them great comfort or it's going to haunt them for a very, very long time. And I know that here at Columbia University, we're spending an amazing amount of resources towards the well-being of staff, but I can only anticipate what might be coming down the road as people process this.
Well, thank you all so much for joining us this evening. Martha, wonderful job. And I think please, everybody, keep going with the information sharing and letting us know what you're doing locally, and we can continue to learn from each other as we go through the different phases that lie ahead.